that's very serious. And so that is adrenal insufficiency because your adrenal gland atrophies. And it takes a while for it to produce enough hormone again to do what it's supposed to do. So the moral of the story with that is when, regardless of whether you're giving, you know, long-term use or a person is on it for maybe a year or whatever, you really need to taper those drugs off slowly and really pay attention to how they're tolerating that, okay? There's other complications that can happen with giving steroids as well, and one of the major side effects has to do with the stomach. Does anybody remember what the major side effect is of giving prednisone or any of those other types of agents orally? Nausea, it could happen, but I'm thinking more serious than that. Ulcers, peptic ulcers. And so the moral of the story there is to do what if you're giving them? Give them with food. You have to give them with something. But you know, they can cause nausea. I'm thinking of a more serious than that, okay? Any other comments? Good? Okay. All right. Let me just spin this over here to the PowerPoints, and I'll log out here. There are 2 slides left on pain. I'm not going to pull them up, but I am going to make a few comments on them. So that's where we're going to go initially. We had, the last 2 slides were really looking at interventions for treating pain, right? If you were to think of interventions that are non-pharmacologic, what might be some interventions that you would try to do to relieve pain in individuals, or that maybe you have even attempted for your own pain? Music therapy or music, okay, kind of helps to distract, maybe focus on something else. What else?
Ice and heat.
Ice and heat, good ones, right? What does ice do? Vasoconstriction, so there's less inflammatory mediators released in the area, and vasodilation, which brings fluid to the, which do we use first? Ice first, right? And when we're looking at injury, okay? So you want to minimize the amount of swelling in the area, and that ice does that as well. What else might you try? Massage, it can. Depending on where the pain is, and like a foot massage or you know, again, it depends on where that pain is coming from. So it can help. You just have to be a little cautious about that. But definitely, what else? Acupuncture is kind of a Eastern method, but can be very effective in some individuals. Biofeedback, transcutaneous pain units that are actually applied to with an electrical stimulus that can be useful as well. Okay, relaxation techniques would be another one. Everybody's going to be different in terms of how they respond to that. So let's talk about pharmacologic therapy in the treatment of pain. What drug class have you been administering to your hospitalized patients? What drug class are you using to treat pain? The opioids? Yes, the opioids. How do they work? How do they work to treat pain? Where do they work? Where do they bind? Opioid receptors, right? And when they bind to the opioid receptors, we use them to treat acute pain, and we also use them in combination with things like Tylenol or aspirin to treat, you know, mild pain. Well, what do they do when they bind to the opioid receptors? The perception, the kind of, yeah, so they change a person's perception of the pain experience, don't they? And they give a person a sense of euphoria. So they're very important. What's a common side effect or something that can happen when you give opioids? Is that common? That's not common, okay? So get that out of your head. It is a risk if you're giving large doses, respiratory suppression, but is it common? No. So that's not a common side effect or manifestation. Yes. Constipation, because it decreases gut motility. right? So it decreases peristalsis. So, you know, when you're looking at somebody after surgery then, what's their risk? What's the risk to the gut? An ileus, right? A paralytic ileus. What things contribute to that right after surgery? There's like 3 different things contributing to the risk. The effects of anesthesia. What else? Decreased movement, you know, they're less active, and the opioids, right? So those 3 things are going to contribute to the risk of paralytic ileus and constipation. So what are some interventions you're using to counteract that? Get them up, get them moving. What else? Stool softeners, like what? You're right. Docusate. Docusate is one of the ones that are colace. You might have heard it called that. So that's some of the things that you can do. But one of the best things you can do is get them up moving. And then what else do you want to do once they're eating? Give them what? Encourage what? Fiber intake and fluids, right? Very important kinds of things. Is addiction common with opioids? It is not common. It is not common. That is a myth, okay? Most people who are on opioids will not ever be addicted to them. They're on them for very short amounts of time and off of them fairly quickly, right? We switch over from opioids combined with your NSAID sometimes or Tylenol, and then they gradually get over to just Tylenol, okay? So, or muscle relaxant, things of that nature. And the key with treating pain is to get it under control, right? Keep the plasma level going there so you're not doing one of these. They're not 10, 5, 10, 8, you know, that you keep them at a level that works for them. So that's really important. Keep a steady serum level. Okay, non-steroidal anti-inflammatories are also used as a drug class to treat pain. How do they work? How do they work? Non-steroidal anti-inflammatory agents like ibuprofen, okay, good. How do they work to treat pain? Where do they work, centrally or locally? Locally at the site of injury, right? What's released at the site of injury are prostaglandins and other agents. Okay, so one of the things that the non-steroidal anti-inflammatory drugs do is they inhibit the COX enzyme, cyclooxygenase enzyme, because that helps them release more prostaglandin. So why in the world do you give combined drugs, opioid mixed with a non-steroidal anti-inflammatory or Tylenol? Why? They help control pain in 2 different ways, locally at the site of injury and also centrally. So that gives better pain control, all right? It also allows for one other thing, a little less opioid that needs to be given, okay? So you need to know the mechanisms by which your drugs work and how that works with the pain experience. All right. I think that's all that I wanted to really say about that, okay? So just some things to pull in the pharmacology that you've been learning and that we're on track with that, okay? Any comments or questions? So we're getting into the neuro stuff now. We were chapter 36 today, and we'll get started on chapter 37, and we'll finish chapter 37 on Friday. We don't have any more quizzes, right? More quizzes. So again, for the final exam, it's half old material, half new material. So there will be at least 1 question on each, content area. If we spent 2 hours on a content area, there'll be likely 2 questions on old material, so you can kind of gauge it that way. Okay. The chapters that have worksheets, there'll be something related to the worksheet topics, the content topics, so you can use that as you have for your study guide. Okay. Yes, Andrea.
Will there be questions that we already seen in tests, or
I never use, good question, I never use the same question, but it might be the same content. So I'll just ask it a different way or something else related to it. I use angina as a really good example. There's terminology you've heard all semester long, so don't be surprised if you have to define some terms like hypoxia and ischemia. I mean, I think those are things that we see with everything, right? And, well, not everything, but close to everything. So those are, if that helps to answer some of your questions. Anything else? Any other questions or comments? How are you doing? I don't know yet, but there may be. I haven't written it yet, but I might have some terms on there for you to define instead of picking the definition, okay? And I'll let you know on that. It is Wednesday of finals week, which is the 8th, and it's 8 to 10. And you should have your other finals at other days.
No.
No?
They're back to back.
Right downstairs.
Okay. You don't have finals on anything else?
Well, not that week, not that week, not that week.
Well, right, for 2 credit classes, it's the last day of class, okay? So I'll have to talk to Barb. Barb. Does anyone have just a sheet of paper I can have from your, I didn't bring a pad of paper down with me, I do every other day.
You need a Post-it? I got
A
lots of
Post-it? Sure, I'll take a Post-it.
I got a good one.
Sure, thank you. So you're basically free on Monday and Tuesday to take a final?
Yeah.
You have what?
I have to take a jury for my music minor.
Okay, but Monday and Tuesday are open if we change one of the finals.
Wide.
Why?
I said wide open.
Oh, okay.
We'll just maybe take both of them on the same day. Okay, so we have 8 to 10. Patho is scheduled for Wednesday, and professional practice 2 is Wednesday at what time?
10:30.
All right, I'll talk to Barb. Figure something out.
Thank you.
Which would you rather take first?
Probably the
Patho.
Really?
Yeah.
Yeah.
More time to study professional practice?
No.
Maybe not.
We're gonna study Patho.
As long as we move one, but I mean, it kind of depends on, I'm giving a final Monday morning 8 to 10 already. So, you know, that's in another class. So we're gonna have to see who's available when as well. So we will figure it out though. Thank you for telling me that.
Like 3 o'clock.
I think it's 6 o'clock in the morning. 6 to 8, get the sucker over with. All right, anything else? How you doing elsewhere, you know, just with, you're done with clinical? Done with care plans, what's that? Oh man, what'd you do this Sunday? That was awful. I had my big honking golf umbrella out in the morning walking my dog, and it was just coated with snow, and I keep shaking it off. It was just, they got a lot. Are they? It's gonna be 50, close to 60 on Friday, Saturday. So you're good, right? Saturday was sunny. That was great for the, and so my fundraiser that we did for the turnout. A lot of energy. That's what we do. You took a good quiz, are you? Yeah. So I'm nice once in a while. That's hard though, but I'm nice for the year. All right. So let's talk chapter 36, all right? We need to spend some time looking at disorders of neuromuscular function. Okay. So when we're looking at the organization of movement, one of the things that you remember from A&P and reading in the chapter is the motor system and how you move kind of has a functional hierarchy, right? What's at the top of the hierarchy? Yeah, the brain, and specifically it would be the motor cortex, right? The motor cortex, which controls the upper, you know, it's the upper motor neurons, lower motor neurons, that's kind of then the big charge, right? The motor cortex in the brain, upper part of the brain, it's actually in the frontal lobe, is the highest level of motor function that you have. So it's important for precise movements, flexor muscles, etc. It's very important, and that's controlled by the motor cortex. As it moves down, what's underneath that? If you look at the brain, there's the frontal, it goes down then to what? The brain stem. And part of the brain stem, what's attached there is your basal ganglia and also your cerebellum. And remember, the cerebellum is important for balance and such, right? So the brain stem, it also includes the pons and the medulla, are very important. It's kind of, you know, there's a lot of, I would say, other functions there as well, like your respiratory center, and that are also part of the brain stem. So very important. I would say one comment about the basal ganglia, because it comes in handy when we talk later about some of the motor disorders that we see is that it's important to posture and crude movements. That's one of the important things about the basal ganglia when you're talking motor function. Okay, I think that's, and then to the spinal cord, right? So the signals go out to the spinal cord, and then from the spinal cord to your muscle fibers, right? So if you think about kind of the hierarchy, starting with the brain, or start in the lower end and work from the muscles up, that becomes important to you as you think about motor function. So neurons then, that control motor function are called what? Motor neurons. There you go. It's kind of an easy one. A motor unit consists of the motor neuron and what it innervates, which is what? What moves you? The muscle, right? And so when you're talking about the motor unit, it's just referring to that motor neuron and then the muscle fiber that it innervates. So those things have to work together. The upper motor neurons, think upper brain, extend from the cerebral cortex to the ventral horn of the spinal cord, okay? So they start here and work their way down to the spinal cord. What controls the lower motor neurons? Hierarchy, right? Up here, the upper motor neurons control the lower motor neurons. So if something goes wrong here where you damage your motor center, can that affect the lower motor neurons? What's a good example of that? The spinal cord injury is not upper, so hold that thought. Those are lower motor. Stroke, really good example, right? Really good example. If you damage the motor center because of a stroke, that could lead to paralysis or discoordination, uncoordination of your muscles. And it could be your swallow, it could be, you know, an arm, it could be a whole side. Depends on where that damage has occurred. Okay. Head injury is another good example. A tumor that's invaded the motor center. Any of those types of things that damage the cerebral cortex, that frontal lobe. Okay. Two motor systems when we're looking at this. One is the pyramidal motor system. That originates in the cerebral cortex. It provides coordination or control of your delicate movements, your fine motor movements. Definitely a stroke could impact that, right? Have you ever seen people with a stroke that have lost some of their fine motor skills? Okay. Also, spasticity might be one of the side effects of damage to that area as well. The extrapyramidal, have you heard that term in pharmacology? Mm-hmm. Yeah, what does that mean? Which is caused as some of the mental health drugs can lead to extrapyramidal side effects. So when we're talking extrapyramidal motor systems, where does it originate? The basal ganglia, okay? The basal ganglia. And this is your crude supportive movement. So things like involuntary movements, I would say muscle rigidity, those would be some examples. Doesn't lead to paralysis, okay? That's not what you see with those types of things. Another example would be tardive dyskinesia. Parkinson's disease, that's damage to the basal ganglia. Okay. We're talking about the basal ganglia there. All right. So where are the lower motor neurons located? In the ventral horn of the spinal cord, okay? And these are your spinal nerves. When you sever, now you're on track, when you sever the spinal cord at a particular area, what do you lose? You lose motor and sensory function below that. If it's a complete injury, in other words, complete damage or severing of the cord, you lose everything below it. Partial loss, there's different syndromes that you can have, and we'll talk more about that. But if there's partial nerve damage there, you might see a variety of different things depending on what part of the cord has been damaged. It could be sensory, it could be a combination sensory and motor, but it's not a total loss, okay? So there's different types of things that can happen with cord injury. Right. So when you're looking as nurses now, what are you concerned with? Whether it be damage to the brain or damage to the spinal cord or even to the peripheral nerves, you need to be thinking about what sorts of assessments might you be thinking about. When you damage the motor system, you're going to have clinical manifestations. So you may see things like differences in your muscle characteristics. What might be an example of that?
Deformity.
Atrophy, motor tone, size, okay? So those would be some examples there. So tone, strength, and size are muscle characteristics that we assess depending on the type of injury. Certainly with a partial spinal cord, we're going to be assessing their strength, and so forth. Spinal reflex activity. Remember, these are your involuntary motor responses that are initiated by a stimulus. And have you learned how to do some of those reflexes tests in the lab? Yeah, you bet. Okay. And then certainly motor coordination. So these are some things that, what might be some coordination things like finger to nose, okay, or your heel down your shin. Those are looking at coordination, aren't they? Okay, so let's take a look then, upper versus lower motor neurons. Again, the upper motor neurons start in the cerebral cortex and they move to the ventral horn in the spinal cord, and they control the lower motor neurons. So damage to the motor center here is going to certainly lead to changes in how your muscles function. If you have lower motor neuron damage, you're going to see a variety of different types of disorders as well. Certainly paralysis, hemiparesis, it depends on what part of the cord has been damaged, what part of that unit has been damaged. Okay. You can also see muscle disorders, right? I'm thinking of muscular dystrophy is an example of that, and we'll talk more about that as we look at problems. Okay. So with upper motor neuron damage, remember the upper motor neurons control the lower motor neurons, right? So when you damage the brain, in particular motor center, what you're going to see is a weakness, likely depending on how much of that brain has been involved, how much of that area, and you could also lose some control of your voluntary motion depending on how much damage has been done. You may see some spinal reflexes still intact when there's been a brain injury. You may also see things like hyperreflexia, spasticity. These are just some of the things that you may see with strokes, brain injuries, damage to the upper motor neuron, particularly the cerebral cortex. Okay. So then with lower motor neuron damage, when we have damage to the nerve itself, there has been transection of the spinal cord. There may be a variety of different things that you see here. If you have outright death to the neurons, I'm thinking of, let's look at C3. If you sever the spinal cord at C3, what might you see happening below that? If you completely sever the cord, what problems will that patient experience? What does breathing is going to be impacted, right? The phrenic nerve is innervated by what? C3. 3, 4, and 5. The highest is that C3. So you lose the phrenic nerve, right? And so they might have a little intercostal muscle strength yet, but breathing is going to be a big deal. So they might have shallow breaths, they're at risk for atelectasis and pneumonia. They may be on a ventilator for a period of time during that initial spinal injury, during spinal shock, but they need ventilatory support. Do you think they have much of a cough? No, and there's support that we need to give them there as well if they have secretions that need to be mobilized. Other things that you might see, because the nerves that you've severed that cord, all of the nerve fibers now down to the muscles below that area of injury are not going to be functional. So denervation, when you see a spinal cord injury like that, the muscles aren't going to be used, and so what happens to them? We talked about that at the first part of the semester, they start to atrophy. If you don't use it, you lose it, right? So these are some of the things that you would see. So muscle strength, bulk, and tone are the things that we assess, right? That's one of the things that we can look at. So what are some alterations that we might see when there's a problem with muscle tone? Well, you could see either decreased tone, less than what's normal, or you could see increased tone. Rigidity is also a possibility. We see that in some disorders like Parkinson's disease. Okay? And then also with clonus, what's clonus? Does anybody have any idea what clonus means? It's kind of an abnormal, well it isn't kind of, it is. It's an abnormal pattern of neuromuscular activity where you see involuntary contraction and relaxation. Contraction and relaxation, okay? So it's kind of going back and forth between involuntary contraction and relaxation, and it happens in the skeletal muscles. Other things that can happen would be muscle strength issues. I'm thinking of somebody who has, again, I use spinal cord injuries up on C3. You wouldn't have, if it was completely severed there, you would lose your diaphragm activity. You might have a little bit of intercostal, but not a whole lot. So, and C2, you would lose all of that. You would lose all of the muscles of the chest altogether. So usually people who have a spinal cord severing at C2, they die most of the time. I have seen a couple survive. Someone has offered maybe CPR at the site, and they have come in, but they have everything lost below C2. So they're, on a ventilator, and they need total care. All right. So what are some terms you're going to see in nursing practice that describe motor function? How many of you have heard of plegia before? Okay. So weakness in both arms is paraparesis. That's one term. Weakness of the right arm and right leg is hemiparesis. Hemiparesis, another term that means the same thing as hemiplegia. That's where both limbs on one side are impacted. Paraparesis and paraplegia. What does that mean? Paraparesis, that we use those terms interchangeably. Paraparesis or paraplegia. It's right on the side here. Para, meaning both upper limbs or both lower limbs. So paraparesis or paraplegia, those terms are used interchangeably. All four limbs, quadriplegia, you've heard that term before? The other term that means the same thing is quadriparesis, okay? So paresis and plegia are often used interchangeably. So the prefix of those tell you how many limbs you're talking about. Okay. Okay, so on the next slide then, what would be the terms for the following? A defect causing weakness in both arms. What would be two terms you could use there? Both arms. Is that para or quadra? Para what? Paresis or plegia, right? Paraparesis or paraplegia. How about weakness in the right arm and leg? Think hemi as hemisphere, right or left, right? So it would be, weakness in the right arm and leg would be either hemiplegia or hemiparesis, right? And And then inability to move one leg. What's the prefix for one? Mono, right? Monoplegia. All right. Okay, let's think back to anatomy. Oh, your favorite class. So, think of the motor unit. What is an important chemical that is released from here, crosses over, and causes muscle contraction? Acetylcholine, right? Acetylcholine is very, very important. It's released from the motor neurons. It crosses the synaptic space, and it's important because when it reaches the receptors, then it causes muscle contraction. Once it's used, it gets broken down to acetylcholinesterase, right? If you remember that from A&P. And what happens once that occurs? Do the muscles continue to contract, or do they relax? They go into the relaxation state, right? So you need acetylcholine to contract, and then once it's broken down, then it's able to relax. But as long as you have acetylcholine there, your muscles are going to contract. When you have diseases of the motor unit, you can see weakness and wasting. And we also can give drugs that inhibit acetylcholine from binding, like curare and other muscle paralyzing agents. Okay, it can actually cause, it causes acetylcholinesterase not to be present, and so it causes acetylcholine not to bind, so that your muscles are relaxed or literally paralyzed. Okay, so they're not going to contract. We have lots of good drugs that do that. We can put people in literally and when you do that, if you give a drug that does that, you stop muscle motion, including breathing, right? Can the person still think and hear you? They can't talk to you, but they can't open their eyelids. But imagine how terrifying it is if you give someone a neuromuscular blocking agent without giving them also something to help forget, or an amnesic agent, or a benzodiazepine to help them relax. We use muscle paralyzing agents pretty often in certain critical care areas, in your really sick patients where you want to reduce their energy expenditure, reduce their metabolic processes. We can put them in we can literally give them a drug and cause their muscles to stop working. But when you do that, they're on a ventilator, and you're going to give them a benzodiazepine like midazolam or something to help them relax, because you don't want them to. That is the terrifying experience. You're laying there, hearing everything, not being able to swallow, react, open your eyes, none of that. So it's a very frightening experience. So we use medications in combination to help that patient. Okay, so breaking it down again, remember your lower motor neurons, and then the peripheral neuropathies are actually disorders that affect the nerve axon itself, and then myopathies are muscle fibers. So again, you can have brain injuries where the upper motor neurons can't function well, so now you're going to see, like in the case of a stroke, if it's a left stroke in the motor unit, you'll see hemicresis likely on the right side. Vice versa is also true. When you're dealing with neuropathies, that's damage to the nerve tissue itself. Okay, so you got to kind of think about where things are happening. The lower motor neuron, things like the spinal cord, you're going to see motor problems there and sensory problems depending on the injury. And then muscle fibers are those myopathies, and so you have to kind of think about what's involved in what might you see in your patients depending on the disease and the disorder. True or false? To increase the strength of contraction, more motor neurons must be recruited. Strength of contraction, do you need more? Yeah, yes you do. The motor neuron unit, remember, consists of the neuron and the skeletal muscle fibers. So for a stronger contraction, you need more. You need more units. Okay, so let's talk about some things that can go wrong. What about skeletal muscle problems? Disuse atrophy. Go way back to the beginning of the semester. What does that mean? Disuse atrophy. If you don't use it, you lose it. Give an example or examples from your practice that you would see that. Pardon me? A cast, okay, disuse, I heard cast. So when you take the cast off, you've got muscle atrophy compared to the other side. What else? Yes?
Like once an older adult gets into a wheelchair, it's harder for them to get out of.
Okay, so if they get around in a wheelchair and they don't do a lot of standing or using their lower extremities, they start to atrophy, and they also lose their strength, don't they, because of that? Good. What else?
Bed rest.
Bed rest, prolonged bed rest, right? How many of you have been sick and down in the dumps for a day, laying around in bed, or 2 days, and do you feel great that when you, I mean, even after, at your age, after 24 hours of being down in bed, it takes you a little bit to regain your strength, right? So imagine somebody who is on prolonged bed rest. That really has an impact, and then add age to it, okay? So you can really see some significance there. Okay, so denervation. What is that? Denervation. Loss of the nerve, right? And we talked about that example already when you damage the spinal cord, correct? When you damage the spinal cord. So the muscle loses contractile proteins, and over months it changes to literally fibrous connective tissue. And that's what happens when you denerve, cut the nerve. Muscle dystrophy. Muscle dystrophy, these are a group of genetic disorders that produce progressive degeneration and necrosis of skeletal muscle fibers. So degeneration and necrosis of the skeletal muscle fibers. What we see is eventually, has anybody ever seen somebody with muscular dystrophy? Was it Duchenne's? Yep. Likely, that's the majority of muscular dystrophy that we see is Duchenne's. It's the most common one that we see out there, and it's an inherited disorder. But what happens is the muscle fibers are replaced by scar tissue over time, and fat as well. So you see pretty significant muscle weakness. Duchenne's is the most severe and the most common. Becker's is another. I've never dealt with Becker's. I've seen and worked a little bit with Duchenne's. And unfortunately, it's an inherited recessive disorder, so the mother passes it on to the male offspring. And with Duchenne's, we start seeing it muscle involvement and weakness at ages 2 and 3. So it starts quite young. Okay. So there's also, so that's, an inherited disorder that can lead to muscle problems. This is a problem at the neuromuscular junction. There are several things here. Remember, it's very important for the motor unit and skeletal muscle to work together. Botulism is a good example. Botulism poisoning can actually cause, it's a neurotoxin, and it blocks acetylcholine release, okay? And it's pretty nasty. So you see paralysis in these patients. I've never worked specifically with botulism, but it's pretty nasty. There are gram-positive bacilli found in our soils, right? And they're in the intestines of some animals as well. So if you ingest contaminated food, that's one of the ways that you can get botulism. Also from undercooked meat, right? As well. So just bear that in mind. Curare is another example, and there are other neuromuscular blocking agents that decrease the ability of acetylcholine to work, so that whole motor unit is not going to function. There are also some organophosphates, which we have learned from research, that have an impact on how acetylcholine works, and some of them have been banned now from use because of its neurotoxicity. So organophosphates have been removed from the market in many instances because of their effect on the nervous system. True or false? Acetylcholinesterase stimulates the release of acetylcholine. Is that true? It breaks it down, doesn't it? Yeah, so that is false. it's important so those muscles relax again. Okay. Let's talk about myasthenia gravis. Myasthenia gravis is an autoimmune disease, and we don't know exactly. There's multiple factors here, but these autoimmune diseases. We don't have an exact cause. What we do know about myasthenia gravis is there's loss of acetylcholine receptors. So there's a loss of receptors in the neuromuscular junction. We think the antibodies, a person's antibodies degrade those receptors, so there's fewer of them. About 75% of people with myasthenia gravis have had a thymus gland tumor or disorder. Usually it's a tumor. Again, we don't know the exact cause, but that has been a link in about 75% of the myasthenia gravis that we see in practice. So what happens is muscle weakness in these individuals. If you have fewer receptors, you can about imagine how well those muscles are going to work. And so the muscle weakness begins in the eyes, and what we first start seeing is ptosis, which is, a droopy eyelid here. And gradually over time with this disease, it gets more progressive. There's a few things we can do, a history and physical exam. There's also, it's called a tensilon test. It's a drug called tensilon, Tensilon. What that does is it breaks down acetylcholine. So if you see a slight improvement in these folks, it's diagnostic. I'm not going to ask you about tensilon, but it is one of the tests that we can do. And then we can counteract that with another drug to help inhibit the breakdown of acetylcholine. It's called viostigmine. I don't know if you've talked about that in pharmacology. And I'm not going to ask you about myasthenia crisis. You'll talk about that in professional practice too next semester and the management of that. But it does lead to respiratory failure. So peripheral nerve injuries. So we're seeing some very big differences in terms of where the effects are in the nervous system and the motor system. Peripheral nerve system disorders involve the neurons that are located outside of the central nervous system. Okay, so a couple of different things here. It can involve a single nerve or multiple nerves. Peripheral nerves can be surprisingly resilient, but when I injured the nerve in the ball of my foot, or not the ball, but the arch of my foot, it took probably over a year for me to regain to lose that. I had tingling and numbness and not real good use of a certain part of my foot. And over time, it really healed and came back 100%. So it's kind of interesting how peripheral nerves can be pretty resilient. A couple different things that we can see related to peripheral nerve injuries are damage to the lower motor neuron cell body itself. That means damage to a segment of the cord or multiple segments of the cord. Could be to the peripheral nerve itself, like because of an accident, and also damage to the myelin sheath. Can you think of demyelination disease?
MS.
MS, and we're going to talk about that. Okay. So peripheral nerve injuries, this is what we use in practice today in terms of terminology. Mononeuropathies, some things that can lead to this that I've dealt with are trauma, infection, overwhelming infection, compression injuries that damage the nerve area. Fractured bones frequently involved. Bone is very vascular, and so it involves the blood vessels in the area, and it can also involve the nerves in that area and lead to problems. Have any of you ever twisted an ankle or broken a bone or tore ligaments and had nerve issues related to that afterwards? Anybody? Nobody? Okay. But you can see nerve damage as well. It can resolve, and it can be some permanent minor losses as well. Okay, carpal tunnel syndrome is another example. It's an entrapment mononeuropathy is what we see there from repetitive use of that part of the wrist. And usually what most people experience there are paresthesias. What are paresthesias? Tingling, numbness in that area. Okay? surgery can release that nerve, and the pain is usually the first, second, third, and digits of the hand is where you commonly see carpal tunnel discomfort. Guillain-Barré is a really good example of a polyneuropathy, and Guillain-Barré can be life-threatening. One of the things that is distinct about Guillain-Barré is that it is a progressive limb weakness, and these individuals lose reflexes. There's several different types that we're seeing out there now. We think that it's related to a virus that a person has. Epstein-Barr virus is one example. There are others out there. But it is an ascending type of progression for those individuals. So it starts with the lower extremities and moves upward. Okay? It can start with tingling numbness and outright loss of motor function. I have worked a fair amount with Guillain-Barré, not so much recently, but in the 80s and early 90s, I dealt with a lot of Guillain-Barré. And not only is it ascending, but once it reaches this area, what's in this area right here? They stop breathing. Okay, potentially they can stop breathing, and the ones that I've dealt with have some of them in ventilators. One of the ways to help, and it does resolve, surprisingly, is to do a plasmapheresis to get rid of some of the antibodies that are present in the bloodstream, and that seems to about 80 to 90% recover within the first 6 months to a year. All the Guillain-Barré patients I've dealt with over time have all recovered, so that's kind of interesting. 80 to 90% of them recover within 6 months. Okay. Let's take 5 minutes. Let's take breaks. Get up, stretch, get a drink of water, go out and scream in the hallway. George is always so animated. I love it. You're a Brewers fan, huh?
Yes, ma'am.
Yeah.
7 in a row.
Hey.
We're doing well.
Wow, that's pretty cool. That's pretty cool. Sorry. Exactly. Thank you for contributing. Whether you get it right or not, it's nice to have people say thank you. My mom said ours. Where are you going to be working? Have you been involved in Is it it's specific types of these are patients who have their
She said that you can't like has nurse for fire, but you like he bought all mine, right? So I didn't say that. I didn't want to use like I know.
When will you be full time?
Were you there for the phone
It's like you're waiting for. Yeah. Trying to calculate. I need like an 85 out of 100 to be
In skills or in here?
Do you have apples
I was really thankful because
Yeah, yeah. I kept telling my grandmother, yeah, when you're done tonight, it's fine. Yeah, we'll just hang out there. Oh, yeah.
I was out.
What's the 3 on 3?
Was yours up?
No, but
On the worksheet. So I can get I see what you're saying. So I could get like an 80 and then
Okay, I have a question. This is really off the mark, but I see a lot of you have Apple computers. One of the people that I'm going to be dealing with in Tanzania on our trip is interested in an Apple computer, and something that's not real expensive, but that has reasonable capabilities. I don't know anything about Apple computers.
They're not real cheap.
Yeah.
bottom of the line is like $1,000.
You've got to be kidding me.
No.
Yeah, they should go for
Really?
Yeah.
There's a lot of
Because
like
you're paying for the
HPs.
I name, the Mac name.
I mean,
should say.
if you get an iPad, the iPads, they have like a connecting thing to it where you can get a keyboard for it. So it's like the same thing as iPad.
And you can do like Word docs and stuff on it.
Yeah.
On the iPad.
Yeah.
See, I don't even know where to begin when it comes to
My mom just got a really nice new like HP with the Windows 8 that's like similar to Mac for like $500.
Really? Well, we'll have to give that person some information then about what they might want to be thinking about. I mean, I know you pay so much for.
I know, they're really expensive.
Were you going to say something about it? Yeah. So. Okay, I suppose we need to continue on talking about neuro stuff, so. Okay. That was interesting.
What's a BN84?
So I wonder what happened there.
Yep, 92s and 81s.
It just like snanked out. I think we're losing our ball. It seems.
You lost them.
Well, I want to. Oh yeah, it's giving out on us here. I'm going to continue with this though because we need to get through a little more today because I can't leave everything up till Friday. We only have 50 minutes on Friday. So when we're looking at back pain, I want you to take a look at that section in the book. 2/3 of the people in the United States experience some type of back pain in their lifetime. 2/3. How many of you have back pain? You don't have to raise your yes. All of us in this room, at one time or another, whether it be neck pain or lower back pain. So please take a look at that. Very important. As we age, the disc becomes less, resilience not the right word, less hydrated. It can be, our spines take a tremendous amount of work that we do, and that's why body mechanics and nursing is so important because of the risk of back injuries and so forth. If we have partial dislocations like subluxations, it can actually cause trauma to the nerve, not the nerve, the disc itself. And disc is like an onion. It has multiple layers. And so you can have, it can extrude and
Sure.
That's how it, yeah. And so what happens is if the disc presses or compresses the nerve in that area, it can be quite painful for individuals. And so having a good, strong core is one of the things that helps prevent that from happening. Okay, the next slide, the basal ganglia dysfunction that can occur there. What happens is the basal ganglia control your movement, a big part of that. So it's especially important when you start and stop your muscle activity. Okay, so think about that. Disorders of the basal ganglia lead to things like tremors. All right, tics is another manifestation that we have, and then hyperkinesia, which I've listed several of those for you on your slide. So these are just some things to bear in mind when you're dealing with basal ganglia. So then you have a question on your next slide, I believe, and that is, which disease is a result of basal ganglia dysfunction? Yeah, it's Tourette's, okay? Tourette syndrome, we often see tics with that, and it's typically the basal ganglia that dysfunctions. When we're dealing with Parkinsonism, okay, it's a very progressive, degenerative disease of the basal ganglia. If you've noticed, one of the things that I want you to get out of these different neuromuscular disorders is, one, where's the problem? Where does the pathology occur? So with like Guillain-Barré, well, what happens? Well, it's, what is that? And then for Parkinson, what is that? What's the pathology that happens there? And because of that, what are some of the manifestations that you're going to see? As nurses, you need to be able to recognize those things. Next semester, you're going to talk a lot about how you manage and care for those individuals. The Parkinsonism is progressive. It's a disease of the basal ganglia. What you end up seeing is tremor, combination of that with rigidity and bradykinesia. That's slow movement, right? Bradykinesia, brady meaning slow. Parkinson's disease is the second most common neurodegenerative disease that we see. The number one is Alzheimer's disease in the United States. With Parkinson, it usually begins after the age of 50, although you think of someone who is in the media and an actor that's had it younger than that? Yep. Fox, yep. What's the major problem? Basal ganglia, depletion of what neurotransmitter? Not acetylcholine. Thank you for thinking of that, though. Dopamine. It is dopamine, and you will need to know that. Dopamine is very, very important. All right, so we have to give them drugs like levodopa, as you talked about that yet in pharmacology, so think Parkinson, dopamine, levodopa, replacing that dopamine. Okay, so upper motor neuron disorders then, we're looking at things that affect the brain specifically. I'm just going to turn this off since it's a problem, and I'll get a hold of IT and let them know we lost the bulb. So with upper motor neuron disorders, again, damage to the motor center, things like stroke, head injury are really good examples of that. So those are pure upper motor neuron disorders, right? Or things that are purely upper motor neuron. Things that are mixed upper and lower are things like ALS, and that's listed for you on your slide. ALS, amyotrophic lateral sclerosis. It's 2 cases in every 100,000. It doesn't sound like much, but I have a friend who lost his father to this. It usually starts in middle to late adulthood, and it's more common in men. Once a person is diagnosed, they live 2 to 5 years. It's pretty devastating. It damages the anterior horn of the spinal cord, the brain stem. It damages cerebral cortex. So again, upper motor and lower motor neuron involvement with ALS. Very, very damaging. We don't know what causes it, and there is no cure. And the way to treat it is we treat the medical problems as they arise, or prevention is very important. We try to prevent severe disability and help maintain some quality of life, but eventually it really takes over. There is a new drug out there today that helps, but it's it's not curable. Multiple sclerosis is another problem, and there's destruction of what? The myelin sheath itself. So what happens to nerve conduction? It slows down, doesn't it? So if there's 1 in 1,000 persons, so it is in the United States, it is a very common disorder then in the U.S. Onset is young, 12 to 40 years of age is onset. We do know it's an autoimmune disorder, and there seems to be genetic susceptibility in individuals, so there's a genetic piece as well. Some of the speech is usually involved, swallowing can be involved, eyesight can be involved, absolutely muscle strength is involved. The gait and coordination are going to be impacted because you're losing that nerve conductivity down the myelin. The myelin sheath is destroyed, so you're not going to see good coordination there at all. All right, the question you have on your slide is which disorder is caused by damage to both the upper and the lower motor neurons? And that's things like that are good final exam questions. They ask you about Parkinsonism and ALS and the pathology of muscular dystrophy, things like that. Okay. Acute spinal cord injury. When we're dealing with spinal cord injury, what age group do you think is most impacted by spinal cord injuries? Age is what?
Teenagers.
16 to 30. 16 to 30, risk-taking group. What's the most common cause? There's lots of causes, but on the top of the list, accidents. Which kind? Motor vehicle crashes. Motor vehicle crashes. Other types of things that can cause this certainly are going to be diving accidents, falls, and so forth, but motor vehicle crashes are on the top of the list. When you're looking at spinal cord, again, remember that you're going to see sensory motor involvement, either depending on if it's complete damage to the spinal cord, everything below it, you will lose all your sensory and all your motor if it's a complete severing of the cord. There are different syndromes if you have partial involvement of the cord, depending upon which part of the cord is involved, and I won't test you on those. Your book does a really good job with those. You'll cover them a lot more in professional practice too, but you may have a combination of sensory and motor dysfunction depending on what part of the cord is involved. In addition to what happens if you stretch or injure that spinal cord, remember that you also have lots of blood vessels in that area. And so blood vessels are disrupted, they rupture. You can see swelling in the area. Many individuals experience spinal shock for several days after the injury, and spinal cord shock. And I dealt a lot with spinal cord injuries in Madison. Unfortunately, way too many people diving into shallow ends of the pool that were intoxicated and so forth. Most common places that we see spinal cord injuries are your most flexible areas of the cord. So you're talking about the C-spine, like between C4 and 6 is one of your more flexible areas of the cord. Lower spine area too, around the pelvic area. Those are some common places that you will see injuries. One of the things that you can see, and we kind of talked about this a little bit with the heart, we're going to talk about it with brain injury, but also with spinal cord injury, is you have your primary injury. That's the tissue that is involved with the impact with the crash. But because of the amount of swelling that goes on in the area and the amount of bleeding that goes on in the area, you can have secondary injury. That means that if we don't minimize the amount of swelling and stabilize the cord, that swelling in the area can extend the damage, okay? It can certainly extend the damage. That's true with brain injuries as well. So really minimizing, we have found that, we'll talk about this in term 3, high dose of steroids within the first 8 hours after a spinal cord injury has better outcomes in patients. The swelling is down. The other piece too that's really interesting about cord injuries, if it's a partial transection of the cord, we won't know till sometimes days or months out what permanent losses there will be. And part of that is because of the amount of swelling that occurs in the area. That compression on that nerve, we won't know until days and months out the permanency of that and how much they've lost. So partial spinal cord, you can take a look at those syndromes, but I'm not going to test you on those. And then the last slide there also looks at the different areas of the cord that we're talking about. You can take a look at that, but again, I'm not going to test you on those. The complete spinal cord injury, again to the upper motor neurons, T12 and above, and then lower motor neurons are T12 and below. You can take a look here. We'll spend a fair amount of time talking about chronic spinal cord injury next semester and acute injury and care of that when you get to high acuity in term 3. So I think with that, I'm not going to say anything more about the last couple of slides on that. Okay? All right. Let me see what the next thing looks like so I can tell if we're going to continue or not. I think I'd like to do a few slides on the next area because you've got a pretty good amount on your slides. So why don't we just stand up though, okay? Stand up. If you need to go get a drink of water, do that. If you need to stretch, move around a little. Take a few minutes and then we'll start talking about brain injury.
I think I can manage 71% on the final. In this class.
Manage what?
I think I can manage getting a 71% on the final.
Oh, that's all you have to get in order to
Get an A?
No, it's going to be, I can't get 804 points.
Like an excess.
12 minutes, just double flap.
It's whatever.
I think I can
Kind of the old-fashioned way where who's never had any visuals before, right? Have you tried some of the nutraceuticals that are like brown rice and that?
This one's dill.
Oh, it's dill.
Yeah.
Oh, I haven't tried the dill.
brown rice.
Brown rice. Yep. Brown rice and sweet potatoes and there's all kinds of things coming up. Yeah, I thought it was Tristan. Am I right? It's Tristan's, right? Yeah, because they had samples at High
Brown rice.
Make your kitchen smell. So have you guys tried the rice crackers?
The almonds.
Yes, the almond and the
Yeah, I tried one.
not fantastic.
Upper deck almond crackers. The ones they gave me. I did not eat them, but I actually
Okay, let's try to get through a few slides, otherwise you're gonna feel really pressured if we don't at least try to get through some of the head injury stuff. And we've got a pretty good amount of slides, and the slides are pretty comprehensive. Anybody deal with brain injury? Anybody ever have a concussion? Is that a brain injury? It is a brain injury. Are we changing our thinking around concussions? Yes, a lot, and we're going to talk about that. So mechanisms of brain injury. One of the things that you see on your slide is ischemia, trauma, infections, and so on. There's several different mechanisms discussed in chapter 37. There are common pathways, though, that in terms of, regardless of whether it's ischemia or trauma or whatever the underlying cause is, there's common pathology pathways that we're thinking about, and those are listed for you on the next slide. So the hypoxic ischemic injury part, there's excitatory neurons or injury amino acids specifically, edema, can lead to injury, and certainly increased intracranial pressure are all part of that. So once again, let's look at terminology here. When we're looking at common pathways, hypoxia, what is that? Decreased oxygen, and where does that occur?
The tissues.
At the
Tissues.
cellular level, right? Hypoxia, what's the leading cause of tissue hypoxia? Ischemia, and what is that?
Decreased blood flow.
Interrupted blood flow, and so decrease in blood flow, it can happen to any organ, right? Any body part, your lower extremities. In this case, we're talking to the brain, right? So hypoxia, you don't get enough oxygen, the cells in your brain don't like that very well. What kinds of things can reduce oxygen levels? High altitudes, okay? How many of you ever walk in the mountains? Do your muscles like it too much when you're flatlanders? It takes me at least 3 days or so to kind of get adjusted when I'm out backpacking in the mountain. We give ourselves at least a day or so to kind of hike, not up real high, like 10 or 12,000 feet, because I don't like it too much until I've adjusted a little. But your muscles go, oh, they just don't like it, because the oxygen level is a little less when you get up higher. Carbon monoxide poisoning, lung disease, any of those types of things can affect blood oxygen and lead to tissue hypoxia. Can the brain withstand hypoxia a whole lot for very long? It needs a constant supply of two things, oxygen and glucose, right? You need two of both those for brain function to do what it's supposed to do. We talked a little bit about the ischemia here. We're talking about interruption of blood flow to the brain itself. What can interrupt blood flow to the brain? Okay, a hemorrhagic stroke or ischemic stroke. How about carotid, in your carotid vessels, and you've got nice, thick atherosclerosis now in your carotid vessels that are supplying your brain. Yeah. So atherosclerosis can impair blood flow, clot that becomes dislodged, and so forth. Cerebral ischemia, two types that I want to talk about. Focal ischemia. What we're referring to there is very specific regions of the brain. Like, let's say, for example, you've got atherosclerosis that's supplying, coming up through the right carotid artery that's clogged, and you end up with a stroke because of a diminished blood flow there. So it could be blood vessel issues. With global cerebral ischemia, what we're talking about there is cardiopulmonary arrest. Somebody stops breathing, and somebody's heart stops. So if you're not breathing and your heart stops, are you getting anything to the brain? Nope. You're going to fall over and you're dead. You're absolutely gone. One of the things that is important here is to start CPR as soon as we can, right? And to try to find out what's caused the cardiopulmonary arrest. If it's an electrical conduction problem, we'll try to jumpstart the heart. If it's another problem, somebody has had, maybe a drowning incident or whatever, we're going to try to correct the underlying problem. Okay. So the next slide that you're looking at here then is looking at hypoxia and ischemia. And one of the things that we know is the brain needs to have a constant supply of blood, and it carries oxygen and nutrients, right? Including that glucose that is so important. So when you don't have a good supply, you switch from what kind of metabolism?
Aerobic to anaerobic.
Yep, aerobic to anaerobic. And what's the byproduct of that? Lactic acid. Is that really very good for your system? It leads to acidosis and major problems, right? The other piece that happens is you use up your ATP stores. What's ATP? It's your energy, right? You need it to do your work. And so your sodium-potassium pump fails, you end up with cellular swelling and rupturing of those cells in the brain, and that's not a very good thing. On the next slide, you've got hypoxia and ischemia again listed here for you, and it tells you what happens when you have interrupted blood flow. So kind of take a look at that. That's really an important slide in the sense of understanding that. So we've got a question for you. What two substances are needed by the mitochondria in order to produce ATP? Glucose and oxygen. So they're necessary for ATP production, and without it, you can't do any physiologic work at all. Okay. So calcium cascade is your next slide there. One of the things that I think you noted if you read the chapter is that with many of the neurologic disorders, there's damage or injury to the neurons. But injury can happen from other reasons, from excessive free radicals, for example. It can be excessive excitatory amino acids. And one of the biggest excitatory amino acids that we're talking about here is glutamate. We've learned a lot about glutamate. We know that in diseases like Alzheimer's disease, brain injury, there's excessive glutamate, and it's toxic. It's toxic to the brain cells. It opens up the calcium channels in the brain. And when that happens, that leads to destruction, leads to injury to those brain cells. We don't like too much calcium. You have to have just the right amount of calcium inside the cell. And this slide here kind of describes what happens when you have too much glutamate, what happens in that calcium cascade. Okay. What does cerebral edema mean to you? Cerebral edema. Fluid on the brain, okay? There's a couple of different things that can cause that. There's vasogenic and there's also cytogenic. Let me give you some examples of both. With vasogenic, one of the things, some of the causes are brain hemorrhage. If you bleed into the brain, that's one reason. Brain injury, let's say that you fall and injure your head. Another would be meningitis, which is a viral infection. So it causes those swelling to occur in the brain tissue itself. Does your brain have much room to expand? If you injure your forearm, for example, have you ever noticed swelling that happens in the area? It can expand out, can it? And it can expand out quite a bit, right? But in the brain, what's kind of keeping it from expanding out? The skull, right? So if your brain swells beyond its limits, what happens to the brain tissue? Where does it push? It has to expand, so it's going to push it through down the brain stem, right? And we call that herniation. If the swelling gets great enough, it's pretty nasty. I've seen it happen a couple of times, and it's not a very pleasant thing. And I can tell you more about that when we get to that. One of the things that we know with vasogenic edema is that intracranial pressures go up. Intracranial pressures go up. And it's going to affect consciousness in a person. With cytogenic edema, what we're seeing here is that there's an increase in fluid in the cells of the brain cells themselves. So not just in the tissue now, we're talking about swelling of those cells specifically. That can happen from a brain infarction, it can happen from water intoxication, believe it or not. It can happen from ischemia, so there's lots of things that can be done as well. In either case, I'm not going to ask you the difference between the two, but cerebral edema, is that a good thing? It's not a good thing, okay? So there's some things that we need to be attentive to. So on your next slide then, what happens here is intracranial pressure is the pressure inside your cranium. Normally, it's going to be less than 15. When you cough, it goes up to about 30, and then it comes right back down again. You have three components under the skull, three things that comprise the content of your brain. Can you list them? What's underneath the skull? What's in there? What's in your head?
Gray matter.
Pardon me? Okay, and that's brain tissue, right? So you've got brain matter. What else do you have in there that comprises your contents? Cerebral spinal fluid, and you have one more thing. What feeds the brain? Blood. So blood, brain, and spinal fluid. 80% of the content under your skull is brain. The rest is your spinal fluid and your blood, right? They have to be in balance. And that's going to be an important concept, and it's Monroe Kelly doctrine, which we're going to talk about here next. So again, really important for you to be thinking about that. If the brain swells, if intracranial pressure rises too great, it compresses the blood vessels in the brain. And now what happens to blood flow to the brain? It's going to be decreased, right? So now you're talking secondary thinking. So let's talk Monroe Kelly. This is a hypothesis that says basically that there's a reciprocal relationship to those three components that are held underneath the skull. So when you change the amount of one of those contents, like let's say blood, it's going to be at the expense of something else, right? So normally, if you have an increase in one of those, like you can decrease another, like spinal fluid can be reabsorbed, it compresses the blood vessels, you get less blood flow. But the bottom line is that normally they should all be in harmony with each other. When one rises, another one decreases, and normally they're kept in pretty good balance. So what can go wrong? What can increase your brain tissue mass?
Tumor.
What diseases, disorders, abnormalities?
Tumor.
Tumors. Tumor is a really good example of that, okay? What else? Edema, okay? Swelling, fluid in the brain from that injury. How about bleeding into the brain? What can increase your blood volume? What causes vasodilation of the blood vessels to increase blood flow to the area? There's an increase in something in your blood. Vasodilation. Think lung disease, retention of CO2, right? Elevation in CO2 causes vasodilation, so you end up with increased blood flow to the brain. And there are other diseases and disorders that can cause an increase in spinal fluid as well, right? There's some malformations that can occur there. So this is an important piece. And what you see on this slide, too, that I wanted you to take note of is cerebral perfusion pressure, which we call CPP. That's how that's abbreviated. We calculate that, and you can see the equation there. You want good cerebral perfusion pressure. What does that mean to you when I say cerebral perfusion pressure? Put it in your own words. What does that mean? Okay, it's actually, that's true. It includes pressure. It's your blood flow, right? It's the blood flow specifically to the brain. It's how much blood is perfusing or directed at your brain tissue. And you want it to be somewhere between 70 and 100 ideally. When it starts bumping lower than that, now you're risking blood flow to the brain. And when you get less than 40, you're in big trouble. When you get less than 40, you're in big trouble. Okay. I'm going to do 3 more slides and that's it today. Okay? So, as nurses, one of the earliest and most reliable sign that you will see in neurology, if you work that area, or anybody, if you see this happen, what's the earliest sign of increased intracranial pressure? What'd you say? Headache. That's a good one. You might see that. You might see that. Level of consciousness. Changes in level of consciousness. So they are fully awake 1 minute and all of a sudden they're difficult to arouse the next, or their concentration is off, maybe they get confused when they were oriented. So level of consciousness. Decreases in level of consciousness is the earliest, most reliable sign. Most reliable sign. And you could have a headache too, but the most reliable sign of increased intracranial pressure is changes in level of consciousness. I'm not going to ask you about the different types of brain herniation, but what happens is, have you heard the term compartment syndrome? Yeah, you can have it in the abdomen, you can have it in the lower extremity like with trauma, and you can have it in the brain. So when you have increases in brain matter or blood or spinal fluid to the point where ICP rises significantly, it can push brain matter down through the brain stem. We call that herniation. That kills you, okay? I was working in neuro ICU, and it was my first week. I had moved from Minnesota actually to Madison, and I was going to school, and I was also working as a trauma nurse in trauma life support. And I had a good cardiac background, surgical ICU background, and ER background, but I didn't work a lot with spinal cords or head injuries yet. So I was kind of interested in learning that area. And so I was working with one of my preceptors, orienting to the unit, and she had to leave early on the day shift, and there was about half an hour left in the shift, and we were caring for a gentleman who had an aneurysm, a brain aneurysm, and we had him on a ventilator. We had him paralyzed with medication because his aneurysm was in spasm, and we needed to get him stable to take him to surgery. He had a probe in his brain to monitor his ICP, and he was doing okay. She actually left to go take care of what she needed to do, and if you look at the next slide, Cushing reflex. I was in the room assessing my patient, and I saw the ICP go up to 80 to 100. What's normal ICP? 10, 15 to 0, right? He went up to 80 to 100. What happened to his brain? The other thing I observed is all of a sudden his blood pressure was off the mark. It was like super high, and his heart rate went down into the 30s. That's one of the reflexes that we see when the brain pressure goes up so high. It's called Cushing reflex. You see those three things together, that pulse pressure, wide pulse pressure, bradycardia, and hypertension. And he herniated. And so we called an emergency. The neurosurgeon was there. We removed the bone flap at the bedside to try to help the brain expand and get him to surgery, but he died. We couldn't revive him. So that was my introduction to brain injuries, in particular cerebral aneurysms. So things can, when somebody herniates, usually they die because it's not intended to push your brain down through the brainstem like that. So it's pretty serious. So you can take a look at those different pieces there, but I'm not going to test you on the different types of brain herniation. Okay, so Cushing reflex, and I think we're going to end there. Okay? All right. And I'll get a hold of IT.
Yes.
New bone.
Is there any correlation with Cushing syndrome and Cushing reflex or?
They're the same thing.
Okay.
Yeah, Cushing syndrome.
Or if you say, like, is that more cortisol?
Your Cushing reflex is related to increased intracranial pressure. Cushing syndrome is related to the cortisol, the endocrine part. So they're different. I have no idea. That's a great question. I didn't even think of that.